Hi, and welcome to the webinar for tonight. Unfortunately, Peter de Jong isn't going to be able to make it tonight. He's out of action for tonight. So you only got me, but we're in for a really great session tonight. We've got Dr. Marisa Sobrine, and she's going to be speaking about pelvic floor dysfunction and sexual health. She has spoken previously on our webinars, but I'll give you another brief introduction. Hi, Marisa. Thanks so much for joining us. It's wonderful to have you here. So just a brief introduction. She's a vibrant obstetrics and gynecology specialist in Durban. You're in private practice in Durban, is that right?
Yep, that's
Marisa?
correct.
And your focus is on not only obstetrics and gynecology, but also aesthetic gynecology, which is quite important and quite interesting. She grew up in Durban, but then moved to Gauteng and went through the Wit circuit, and also did a aesthetic gynecology training through the International Association of Aesthetic Gynecology and Sexual Wellbeing, and been practicing ING since 2013, and done some research on a very important topic of female genital mutilation, which she presented in the Royal College Conference in London. You've received the award of the KCD Women of Wonder, and is a regional ambassador for the annual Spa Women's Challenge. Is that the run?
Yep, that's the one. I'm an ambassador again this year, so we just got rid of the photo shoots yesterday.
Does that mean you got to run very fast, or how does it work?
As long as I'm photographed and videoed running, it doesn't matter how fast I run.
Okay, well, that's good. All right, so you're practicing at St. Augustine's Hospital in Durban, and really the ethos of your practice is to encourage education and female empowerment, assisting women in making individual and informed decisions about their physical, mental, and sexual well-being. So that's a great way to start the session. You can share your screen, and we can start getting it going. While you're doing that, I'd like to invite anyone to just be available for next week's session. We're going to be having Turby de Villiers talking about endometriosis. And yeah, so we're really looking forward to that session as well. Yeah, so we can fire away. Thank you, Marisa.
Okay. Just sharing.
And you don't mind if I interrupt you as we go on?
Anything. Go for it.
Okay,
All right.
good. Thank you.
Okay, so let's start. We're chatting about pelvic floor dysfunction and sexual health. The main focus is going to be a lot of general sexual health stuff because it does apply across the board, and then we'll get into pelvic floor dysfunction specifically as we go further on. I have no disclosures related to the topic. So first, just looking at sex. Sex is something that is also just as it's something very simple, it's also something very complicated, and we tend to think that it is more difficult to assess and manage than it actually is. First part is to note that with different age groups, there isn't really much of a difference related to sexual dysfunction if you actually take the time to discuss with women. But there is a general idea that sexual dysfunction is something that happens as you age. But if we're looking at the first one, we have similar rates of around 30% throughout the different age groups. Also, there's an assumption that the older that women get, that they're just not sexually active at all. But on one of the assessments in COA, we're seeing that women in their 60s, 70s, and 80s are definitely very sexually active. With those in their 80s and above, we've got an 18% rate of sexual activity. And with a different assessment, the ARHP, we have patients, 20% of them that are still sexually active in their 70s. So we can't just stop discussing sexual health at a certain age. All of your patients need to be assessed and need to be optimized. Quality of life is something that definitely affects you as a whole. It's not just that sexual life is something separate from your entire life. And we've got definitely increased rates of low general happiness in patients that have issues related to sex. So today we're going to go around in our little circle here, where I'm going to have a discussion where I'm going to promote your knowledge so that you can improve your patient's help-seeking behavior and also improve the help-seeking behavior of your other colleagues when they are relating to their own patients. hopefully we can get patients towards the right treatment and adhering to this. And this will help to break taboos around sexual health. This is one very important slide. So there are about 2 important slides that you really need to focus on. If you want to switch off in between the 2, that's fine. But for this one, this study looked at patients that had sexual dysfunction related to pelvic floor. And in patients that had pelvic floor dysfunction, we were looking at ones that had surgery and ones that were managed conservatively. The majority of these patients reported that sexual advice was never offered by their healthcare provider. The majority of the studies are only considering something to be an adverse event when we are looking at it from the perspective of the surgeon or of the provider. So we're not really taking into account things like sexual dysfunction often. It's more focused on the anatomical defect that is being resolved. So there's quite a significant disconnect between doctors and what patients are perceiving to be a successful outcome. Women consider functional outcomes such as incontinence, sexual dysfunction, and post-operative recurrence of symptoms as severe adverse events, and they rate this to be equal as an ICU admission or death. And most doctors do not think of these symptoms in that way, but we need to start thinking of it like this. So meeting in the middle could look like identifying what your patient's priority symptoms are before you have a surgery, or to be discussing things like sexual health in your preoperative consultations so that a patient would be able to know what they're getting themselves into. A patient might decide to decline a surgery if it would impact their sexual health, or a patient may just be looking for a way to not urinate during sex or have vaginal flatus during sex, and that may not be something that will be resolved with a pelvic floor surgery. So keeping the focus on realistic post-surgical life is the most important thing, even though for us, our focus wants to be anatomy. Also thinking that elderly patients are sexually active, and depending when you are going to perform a pelvic floor surgery, the patient may have natural aging. And as we have longevity, we might find laxity, we might have a recurrence of symptoms later on, which might impact sexual health at that time, even though it didn't initially at the time of surgery. If you don't feel comfortable managing sexual health yourself, refer on to gynecologists, to sexologists, or to pelvic floor physiotherapists that can help. Okay. So just to go a little bit between pelvic floor hypertonicity and hypotonicity, in the hypertonic patients, they are the ones who are going to have more dyspareunia, more vulvodynia, overactive bladder. They might have more urinary tract syndromes or pain syndromes. And this is the patient who's generally the very anxious patient, the catastrophizing patient, quite the A-type personalities. They may have had previous pelvic floor damage and had rehabilitation for that. So that could be the postpartum patient who is over-rehabilitized, or it may be somebody who's an athlete who has had excessive growth of musculature of that pelvic floor, someone like a ballet dancer or a gymnast. For hypotonicity, this is more the patient with pelvic organ prolapse, vaginal laxity. They may have incontinence of urine, feces, flatus, or vaginal flatus, otherwise known as queefing. They might complain about their tampons dislodging, that they have a decreased sensation when it comes to sex. And here we're looking at the patient that has reduced muscular power in the pelvic floor or poor coordination. They may have been trauma related to birth trauma or different surgeries, and we have not rehabilitated, but also things like obesity and a sedentary lifestyle. So now we're going on to some sexual physiology, and we've got the first poll question. So sex is not as easy as we think. What percentage of women do you think cannot orgasm from vaginal penetration alone? So the options are 20%, 40%, 60%, or 80%. Let's see what you think.
Are those results available yet, Corin?
Yes, I'm just giving one or two more people an opportunity. Give me a second, we'll end it now. There we go.
All right, so this is actually better than I thought it would be. So patients, in terms of our results, came out that for what percentage of women cannot orgasm from vaginal penetration during sex, in terms of 20% rate, 15% of our participants thought that that was the right answer. 40% not being able to orgasm was 25%. 60% not being able to orgasm was a 29% rate, and 80%, which is the correct answer, 30% of our participants thought that was correct. So this is actually better than I thought. In the previous presentations that I've done, a large majority did think that vaginal penetration was the sole way to an orgasm, but the majority of women, over 80%, require clitoral stimulation in order to have an orgasm. Okay, so let's go on to some sexual physiology. With sexual physiology, the blue block in the beginning, we first need to have a relaxed pelvic floor to then create voluntary contractions, which will increase arousal, reach a plateau, and then orgasm is created by a series of involuntary contractions that are first regular and then irregular. So to be able to have sexual arousal, you need to be able to voluntarily contract your pelvic floor. If a patient already has a hypertonic dysfunction, their pelvic floor is sitting at a high baseline and they are unable to relax enough to create a contraction. And they are also sitting at such a high level that there isn't any leeway to create more voluntary contraction and increase arousal. In terms of orgasm, and that being an involuntary contraction, that is more where the patients with a hypotonic dysfunction will have a struggle, because we can't get their musculature to a level where we can get coordinated contraction and enough of a contraction to have an orgasm. The picture that's on the right is just showing that we've got some smaller amount of pelvic floor contraction. This is the voluntary contraction during sexual acts. And then when we get into the orgasm, it is much larger contractions, much larger amount of musculature needed for that. There's an inverse relationship between genital arousal and pelvic floor tension. That's what I was just describing. The picture that's on the left is showing a normal pelvic floor. The red in the lower area is showing normal contraction and showing that we can have relaxation and contraction that is rhythmic, allowing to reach a level of arousal. Looking at the picture on the right, in the patient who already has a large amount of hypertonicity, both in the pelvic floor, so that's in the vaginal region, as well as the lower line is the anal region, they are unable to create any areas of contraction because they are stuck at a higher baseline. Okay, so now for another poll question, and this is a study that was done showing patients different videos. In the control videos, we saw that patients that did not have pelvic floor dysfunction, when they were shown anxiety-provoking videos, they did have quite a strong contraction of the pelvic floor, showing fear. But when they were shown sexual videos, they had enough relaxation to be able to create arousal, and they did not have a large response to sexually threatening videos. How do you think that patients that had prior sexual abuse responded to videos? Which video do you think these patients had the worst response to, the most contraction to?
But quite a few participants, so I'm just waiting until we've got a fair amount of responders. Going up, going up. Okay. So we're going up. Okay, let's end the poll there.
Okay, so out of this, the majority of the participants thought that a sexually threatening video would create the greatest negative response in the patients. Let's see what we've got. So when we're looking at this, we actually see that in patients that have had previous sexual abuse, when they are exposed to a positive sexual video, something like a positive porn, not porn that would be seen to be sexually threatening or aggressive, they actually had the greatest negative contraction of their pelvic floor. And their response was very similar to when shown a sexually threatening video. It was actually when they were shown anxiety-provoking videos that they had a lower response, and neutral videos were the only time that they relaxed their pelvic floor. And this is why in patients that have had negative sexual experiences, asking them to watch porn either with their partner or if they're masturbating is actually going to create even more hypertonicity in that pelvic floor and create more negative ideals from a mental aspect around sex. Okay. So this is another slide to focus on. This is the second most important one. You will get patients that come to you that say, I've tried everything. Or you can already be feeling overwhelmed with how you need to manage a patient who comes in with sexual dysfunction. The most important thing is to realize that pain means the patient is not ready for sex. And at the center of all of this, we've got either a physical pain that did occur or memories of pain that continue to reinforce a negative cycle. Just the pain can create its own link with having patients have a fear of pain, a fear of sex, and choosing to avoid sex. But just that idea around pain can also make you perceive friction from the penis or sensation in the vulva to be more negative and more painful than it actually is. Just the pain can have you decrease your sexual arousal or no sexual arousal at all. And just the pain can have you increase your pelvic floor hypertonicity. But these can also work as a cycle, where the fear of pain will increase the chance that a sensation is painful. This will decrease sexual arousal and further increase the hypertonicity. So what are we supposed to do? Lubricants are not going to solve the underlying sexual act. If you have a patient who is bone dry and unable to become sexually aroused, asking that patient to continue in the same way that she has while using lubricants is not going to solve anything. Lubricants can assist marginally with entry pain related to an inadequate amount of lubrication, but if there's absolutely no lubrication, it means that this patient is not aroused and we need to start back at arousal before we are just going to assume lubricants can solve the problem. Another thing that I've seen patients be prescribed is topical anesthetics and using things like Imla cream during sex. Again, this is not a solution to the problem, and this is just prioritizing male sexual pleasure over female safety. You are essentially asking the patient to be completely numb and do nothing and allow a male partner to have a sexual act that includes her body. Antidepressants are also not the answer. These will lead to side effects like having a lower libido, can lead to anorgasmia or vaginal dryness. I have patients that get referred to me for aesthetic gynecology procedures as a way to solve sexual dysfunction, but those are not going to help for sexual dysfunction. Those are purely for cosmetic reasons. They may help in terms of body confidence or mild issues related to sexual dysfunction. But if you've got something severe, you cannot be using a surgery to solve that. The main thing to remember out of the slide is that if sex is not mutually pleasurable, then it is just masturbation within another person's body. And that is not sex. So we want you and your patients to be able to find a way to explore and communicate what they do like and they don't like. They may not even know what they do like and don't like because all they have ever known is doing what they don't like or feeling a duty towards their sexual partners. So sex is the right stimulus because that stimulus could be something that I definitely don't want at other times. It has to be in the right context and it has to include the right communication. And that's how we can be able to get somewhere with this. So what are you supposed to do as a doctor?
Yeah, Marissa, sorry, so thanks. I think you're raising so many good
Should I
points.
go back up to that slide?
Sorry. Yeah. Did you want to finish that? I just wanted to ask a question, but if you wanted to make a final point.
No, please go for it. I was just going to move on to the next slide.
But you know, your aesthetic techniques that you're using, like your PRPs and some of your O shots and those kinds of things. I mean, they certainly do enhance sexual experience. Isn't that the whole point of some of that stuff that you do, or don't you actually do any of that stuff yourself?
So some of it does. The negative is that we don't have enough large scale studies so that it can be used in webinars like today, and I can give an open free statement of yes, this will be beneficial for sexual dysfunction. There are small studies, they are not well powered, they're not randomized controlled. We have seen some benefits, but definitely not something that we can say that it is a known tool for the management of sexual dysfunction. Does that answer the question?
Yeah, sort of. I mean, in the end of the day, you know, a lot of these things are being done quite widely. So, you know, and I'm not averse to things being done without huge data, but I mean, they certainly wouldn't be getting the traction that they are if they don't work.
Yes, so I'll touch a bit. I will touch on aesthetic gynecology towards the end.
Okay.
But you've already brought up the question already, but I've already answered it.
Okay, great. Thanks a lot.
Okay,
thank
sure. You. Okay. Then moving on. What am I supposed to do as the gynecologist? Understand that your role may just be asking the simple question of if you have any sexual concerns. If you are the one to ask, we're likely to get a 55% rate of patients reporting sexual dysfunction. If you do not ask, there's only a 14% rate of spontaneous reporting. That means that these women are suffering in silence, and if they are not going to discuss sexual dysfunction with their gynecologist, they have nobody else to discuss it with. This is your responsibility. So just like our little cycle, from our discussion and knowledge, it can be as simple as asking, do you have any sexual concerns? There are specific questionnaires. If we're looking at pelvic floor, pelvic organ prolapse, looking at urine incontinence, there are specific questionnaires, and I'll touch on a few more afterwards. For help-seeking behavior, there are different options that you can discuss with the patient, and I'll go into that. You can just refer a patient, that's okay as well. And we need to also make sure that patients have a good understanding of that it's okay to just be heard, that they don't need to actually have the solution. And a lot of patients that I've had have felt better just being able to vent and get it off their chest, even though there may not be options that are feasible in their situation, especially if their partner is not open to being a team player within the sexual dysfunction. Treatment adherence can be something very difficult because habit formation takes weeks and months to get to. And we need to start building positive sexual experiences in patients that may be having sex once a month, once every 6 months, and once a year. So it does take a long time to start to build more positives in people that are not having sex as often. And if we're looking at things like pelvic floor physiotherapy treatments, this may take months before we're starting to get a good effect and the patient can start to feel a more positive response. We want to be breaking barriers. When this patient is doing well, she's going to be talking to her spouse, and the spouse is happy, and the family is happy, and the friends are happy, and she's boasting with her girlfriends. That is what we're hoping for, because it will help more patients to be able to also ask for help with their gynaes. We need healthcare practitioners to address their own bias, and that will mean that more doctors are able to provide more healthcare to women, and to just accept that sexual health is women's health and it's a part of our responsibility. There are some positive and negative predictors in terms of sexual dysfunction. So when you do have a patient that may have some of the predictors of sexual dysfunction, you can also know that you should be asking them even more. Patients who have poor mental health or poor physical health, those that are quite stressed, previous abortions or female genital mutilation, if there's been previous sexual abuse, if they are dissatisfied in their relationship, and those that are religious will have more sexual dysfunction. But protective factors are those that have had sexual education, those that marry at an older adult age, those who perform exercise, those that have positive body image, and those that have daily affection from their partner. The main focus with daily affection, there were two things that were found to work really well. The one is a 20-second hug. It's about the duration of time, and the equivalent to that was a 6-second kiss. So just a peck on the cheek as they are leaving is not enough. We're looking for 6-second kiss or 20-second hug. Things that were thought to be quite beneficial and actually don't play much of a role are things like whether they are currently in a relationship and how frequently they have sex. There are women that are having sex once a year, but it is fantastic. And there are women that are having sex every day, and it is a horrible experience for them. When you're screening patients, it is as simple as asking every single patient that you're seeing, do you have any sexual concerns that you'd like to discuss? Has sex been different since our last appointment? Would you like to change or improve anything related to sex? If you just ask one of those, patients often want to answer the question. Times where I've found it's difficult, if you were the gynae who delivered that patient, they are not going to feel comfortable to discuss sex with you. And it might be worth asking a patient, do you feel comfortable discussing sexual concerns with me if you know that you've been the gynae for the grandmother, the mother, and this patient, because there is a different dynamic there. In perimenopausal and postmenopausal women, it's also important that we are bringing in things like the understanding of sexual desire can change, sexual enjoyment can change. There may be more daily vaginal dryness or sexual vaginal dryness, and asking if they have noticed anything like that. In patients that have had oophorectomies and a surgical menopause, you can ask, since your ovaries were removed, have you noticed a change in sexual desire? Because the patient may not be able to correlate that that was something that was a defining factor, but we would know that there was a sudden change in hormonal level at the time that those ovaries were removed, if it was the cause of menopause. Perimenopausal and postmenopausal sex is quite important because a large amount of patients that present with pelvic floor dysfunction are generally of a middle age and older age. Even though there are large amounts of younger patients with pelvic floor dysfunction, they tend to not present as often. So then we also want to look at the differences related to menopausal sex. In patients that had a natural menopause, they had significantly lower rates of low sexual desire compared to those that had a surgical menopause. So we're going from a 22% rate of low desire in natural menopause to 44% in those that had a surgical menopause, even though it was still aged 50 and above. And in patients that had a surgical menopause below the age of 50, we have rates of 66% of low sexual desire. In the second graph to the right, that is just showing that in patients that did not have an oophorectomy, that their libido remained the same or improved compared to patients who did have an oophorectomy. So if there is an option when you are doing a hysterectomy for a patient that has not yet reached menopause, please consider whether an oophorectomy is necessary. It is something that's generally easy to go back in laparoscopically and take out at a later stage beyond the age of menopause, if it's possible. But if you are concerned about cancer or other things, it's understandable if you have to remove the ovaries. In women that were younger than 65 and older than 65, we had different sort of sexual concerns. Everybody across the board had a lack of sexual interest, but in younger women, they had higher rates of dyspareunia and unmet sexual needs, whereas women who were over 65 had higher rates of difficulty with orgasm and difficulty with lubrication, as well as partner sexual difficulties like erectile dysfunction, which may be from a male sexual partner having erectile dysfunction with age or with prostate surgeries. With menopause sexual functioning, there is definite decrease in sexual responsivity, reduction in sexual frequency, and reduction in libido. And there's an increase in dyspareunia and problems, interrelational problems caused by sexual dysfunction. So with perimenopause and postmenopausal sex, understand that a low sexual desire is not an indication for an antidepressant. There are mood changes related to perimenopause. They may have higher rates of irritability, frustration, and 4 times higher rates of depression. But if we are solely addressing the depression, we are definitely not going to address the sexual dysfunction. And as I've said before, those medications can create low libido, anorgasmia, and poor lubrication. The ideal is to try to help these patients with having improved hormonal balance, because that is something we know that is lacking, and simultaneously be addressing pelvic floor dysfunction if that's there. With MHT, menopausal hormonal treatment, previously known as HRT, transdermal options are superior to oral in terms of side effect profile and risk profile. These can also be given vaginally. Tibolone is one of the only HRTs that does also assist with sexual function, and it does have quite a low side effect profile compared to oral. It also has quite a low risk of DVT. So it is pretty equal with transdermal HRT compared to tibolone, even though it comes in the form of an oral tablet. Vyleesi is considered the female Viagra. It isn't something that's available in South Africa. And testosterone should only be given to patients who have hypoactive sexual dysfunction disorders. Okay? It's not indicated to be given in general to patients that are postmenopausal. Local estrogen therapy, which could be given in the form of a cream or in the form of a vaginal tablet, these are not absorbed in significant amounts into the bloodstream, and so they are suitable in patients of any age. They don't need to be stopped at any specific time of life. They can be used on and off if a patient wants to, or continually. It is safe in oncology patients, and it can be used externally if it's the cream, and internally, but the tablets can only be used internally in the vagina. Patients may also have dryness on the vagina lips, dryness in the perineum, and we also want to create some estrogen in those areas. Lubricants, silicone is going to be the best, but it is a little more pricey. Water-based is next in line. Oil-based, try not to go there because those will break through condoms, but they can be used in older patients if they prefer. Some do when there are cost concerns, but this is comedogenic and you do not want to have acne in the genital region. These can create vaginitis and thrush infections. Patients might need to play around, but a silicone-based is going to be the way to go in terms of hypoallergenic, and one that I've found to work in my patients that are allergic to everything is called Uberlube. You can only get it online. It just has silicone and vitamin E concentrate. There's nothing else in it. In terms of vaginal prebiotics and probiotics, that is something where studies are ongoing. We have found that there is definitely detrimental effects in patients that do not have the correct vaginal biome, but we haven't quite found the exact right way to make the biome correct. There are different organisms that live in the reproductive age vaginal area, and there are different ones that live in postmenopausal. So we can't assume that the same vaginal probiotic is going to work in both of these ladies equally. At the moment, we don't have a lot of good options. There are ones available like Rutarina Fem that does give quite low amounts of colony forming units. If you use something like Now probiotic for women's health, that's got about 10 billion colony forming units, but all of them are not focusing on the correct strains of lactobacillus that we're looking for. And we can't differentiate the amounts between ages. Sexual aids are something that are very helpful in perimenopausal or postmenopausal ladies, but they were often raised to not feel comfortable with them, even though it's something that will work well. Sexual aids do not need to be inserted into the vaginal canal. They can be used on the vaginal lips, they can be used in the clitoral region, they can be placed against the male penis and to allow the male penis to vibrate. And this is something that will reduce the fear of pain related to penetration. It helps females to realize that sex is not a burden, that we can also be using a tool solely for their sexual pleasure, even though this may be a sexual act that is involving a partner. females often wonder and are concerned that their orgasm is a burden and they just want their partner to be able to orgasm and that's the end of it. But sexual aids do help that both partners can feel equal in the experience. We want to try to bring the focus to non-penetrative sex, mutual masturbation, and trying to have positive sexual experiences with good feedback from your partner. That might be difficult if we have a partner that's not on board. Patients also need to be educated that with the decrease in nerve, the amount of nerves in the genital region with aging, with generally having loss of weight as they get older or even gain of weight, that it might be more difficult to access the clitoris. There may be more vaginal laxity, which can cause you not to be able to access stimulation. They need to be aware of these things. Orgasms are not going to be as strong the older you get. It's going to take a longer duration of time to reach an orgasm the older that you get. Okay? We want to have physical activities because cardiovascular strength is essential for sex. Sex is exercise if you're doing it right. We want to be able to optimize comorbidities, and that includes any medication that might be creating sexual dysfunction. Helping mental health overall is also going to be able to help sex, especially patients that have had previous sexual abuse or rape. And in partners, we want to make sure that patients are aware that a partner's medication can absorb into their own genital tract during sex. If the male partner is ejaculating within the female, in their seminal fluid can be things like hyperglycemia in a patient that, the male partner who has insulin resistance or diabetes, or antibiotics that they're taking, or anything else. And that can affect the vaginal biome. The male partner's hygiene can affect the female partner, and erectile dysfunction is also something to work with. Couples therapy can be very beneficial for these patients, for both of them to realize this is not as big of an issue as we have made it out to be, and there are other options that can help us. In terms of sexual debut and dyspareunia, now we're going on the other side and more of the hypertonic issues. Childhood
sorry, can I just ask you, before we move on to the younger age group, do you have any data that has looked at the role of the oophorectomy in the sort of women who are really postmenopausal, like may say maybe women in their 60s you do oophorectomy? Does that impair her sexual function at all? I mean, I know you did talk about those who actually induced menopause by surgery, but do you know of anything where that might have just affected it? Because you do often wonder, do we remove ovaries? And I know often, above the age of 65 or 70 people are often recommending it, but what do you think?
If a patient has reached natural menopause, removing the ovaries after that point will not worsen sexual dysfunction. The sexual dysfunction is worse in patients that have a sudden change in hormonal levels compared to natural menopause, which would allow us a gradual decline. So even if we are giving HRT, it isn't going to replace in as much of a positive way in terms of sexual dysfunction. It may be beneficial in lots of other ways, but for sexual dysfunction, the greatest benefit is allowing a natural menopause to occur at whichever time it was going to occur. And then the ovaries can come out afterwards. Okay.
So that whole thought of keeping that's great. So the thought of keeping the ovaries for the potential testosterone benefit, etc., doesn't really have a lot of scientific basis,
it doesn't
in your mind.
Yeah, it doesn't, because at that point when menopause has already occurred, you've now got a postmenopausal patient, that ovary is doing pretty much nothing. And we've also found that testosterone is not helpful in overall sexual dysfunction. It is only helpful in hypoactive sexual desire. So if the desire issue, the brain level is the issue, that's where it can be helpful, but needs to be given in the right doses to the right patient. But if your issue is related to a orgasmic issue, if it's related to an inability to create arousal, hypertonic or hypotonic pelvic floor, the testosterone is not going to solve those other issues.
Okay, excellent.
Okay. All right.
Thank you.
Sexual debut and dyspareunia. we need to have a better focus on sexual health education. The majority of ladies have received a little bit of sexual education somewhere in the end of primary school, the beginning of high school, and then they have never had sexual education besides that. They may get told how to have sex to create a baby. They may be told how to not contract sexual infections or how not to get pregnant, but that's about it. There isn't a focus on what is sex, how is it pleasurable, discussions around consent, discussions around different ways to have sex to not get pregnant, but to still be able to be sexually active. In patients that do not have early sexual health education, we do see patients that are having earlier sexual debuts. We also have higher rates of sexual abuse. And a lot of the time, these patients have had no education from their parents. And if parents are going to continue to not educate their children, it will fall on gynecologists to be the ones to educate. You may be seeing their mothers or their grandmothers, their sisters or their aunts as your patients. Encourage them to bring young girls for a first gynae visit, which may just be a discussion around sex. It doesn't even need to require an examination if there's fear around that. Of interest, 45% of women under the age of 30 reported dyspareunia in the last month, and out of that, 70% had reported prior sexual misconduct. We need to be looking for other gynecological or pelvic pathologies in these patients, but even when those pathologies have been resolved or diagnosed, because we've created a loop, a mental loop related to pain in the pelvic area, this may be something that is difficult to resolve even when the pathology is resolved. Patients who had a later sexual debut, and that was counted as greater than 18.3 years old, these were patients that did worse. There were patients that had more dyspareunia and more sexual dysfunction. There were patients that had strong cultural beliefs against not having sex early in life. They tended to be more conservative and felt that it was taboo to discuss sex. This is compared to other patients that had an earlier sexual debut. So if you're looking at Finland, Denmark, Germany, their sexual debut average is around about the age of 15, but because there is so much education so early on, they tend to not have issues related to sexual dysfunction compared to different countries like Singapore or Thailand, where the average age of sexual debut is 23. These patients are going to end up having greater rates of sexual dysfunction. There's no correlation between a painful sexual debut and sexual dysfunction later in life, unless the sexual debut was related to sexual abuse or rape. Often gynecologists will be telling patients to prioritize their fertility over their pain. The gynae told me to have sex 3 times a week because I need to get pregnant. There may be PTSD related to miscarriages or not being able to get pregnant, and sex becomes mechanical and more painful. There's also been a prioritization around a partner's sexual pleasure over a patient's own pain. They might feel that they are not an adequate partner, that there's a lot of guilt, there's a lot of shame. But this is mainly because they don't have education and they don't think that they have other options to have a successful and pleasurable sex life. If you've got to, now we're going to get a little more into pelvic floor dysfunction. If there is pelvic organ prolapse or urinary incontinence, this is the type of questionnaire that should be used. And this can be used in patients that are sexually active or not sexually active. It is LGBTQ friendly if you leave out the 2 questions that I've put with the little arrows, because it is still validated if you leave out 2 questions but answer everything else. Other validated questionnaires are the FSFI, but that's only valid in sexually active patients. And the PISQ, the original longer one, has quite a complicated scoring system, but it is definitely more accurate. With pelvic floor dysfunction, masturbation may be one option that patients tend towards so that they can be able to have positive sexual experiences, and they prefer this to penetrative sex. There may be mutual masturbation with their partner and then everybody's happy. But the one frustration that came up is as the patient's sexual desire increases and as patients have more positive sexual experience, that they may start to feel frustration, that they are still not feeling able to have penetrative partnered sex. There's more relationship discord in patients that have pelvic floor dysfunction. Like I've said, they feel unable to fulfill their partner's desire and have feelings of guilt and shame. But sexual dysfunction was never related to females feeling anger, anxiety, or depression. And often that is why they are given the antidepressant. So it's important to understand what are the feelings that the patient's having around sex, so we understand whether the patient has an anxiety disorder or the patient has a sexual disorder. But across all pelvic floor dysfunction, pain impairment was across the board. There was a greater sexual function impairment in patients that had a combination of urinary incontinence and pelvic organ prolapse compared to those that just had urinary incontinence and those that just had pelvic organ prolapse. Patients who pass urine or stool prior to intercourse, it might help them to be minimally beneficial, but generally if their pelvic floor is a concern, whatever they're able to do on their own is going to not be sufficient to how much movement or pressure may be created during the sexual act. The greatest sexual impairment was found in terms of vaginal flatus, otherwise known as queefing, but there was also issues related to other types of coital incontinence, like urine, feces, or flatus. Sexual dysfunction did not correlate at all with the POPQ staging, so women with severe prolapse may have no sexual concerns, and women with minor prolapse may have major sexual dysfunction. Sexual dysfunction also had nothing to do with post-surgical outcomes, and women who had so-called failed surgical outcomes with a genital hiatus of greater than 3.5 centimeters did not report any change in sexual health, although their doctor may feel that that was not a successful surgery. Overactive bladder has been found to be have a significant improvement in sexual function with pelvic floor muscle training, which was improved after 6 weeks of training and sustained for a year, even though we were not able to improve their bladder symptoms. Their sexual function symptoms were able to be improved. Queefing is something that has a very low rate of reporting. It's not really assessed in a lot of the studies, and patients would not voluntarily provide this information, even if we were discussing urine incontinence or fecal incontinence. And they have the greatest rate of sexual dysfunction and poor quality of life. In terms of postpartum, pelvic floor strength is definitely increased with pelvic floor training at 12 months, but we do not get an improvement in female sexual function in the first 12 months postpartum. There is a sudden improvement that happens after 12 months in patients that do or do not have pelvic floor strengthening. So we do want postpartum rehabilitation of the pelvic floor, but we don't want to tell patients that this is going to improve their sexual function within the first year because it hasn't been proven to do that. For hypertonic pelvic floor, also to address that there may be other issues related to that. It's not just going to be the sexual dysfunction, and patients may have other issues like musculoskeletal or urological or GIT issues that also impair their sexual dysfunction. These patients with hypertonic floors have a lot more psycho-emotional distress related to sex, a lot more negative attitudes towards sex compared to those that have a hypotonic pelvic floor. Options are diazepam suppositories using Botox or muscle relaxants, and couples therapy or individualized therapy and sexual education helps them a lot more because there is a large mental aspect, but still to focus on pelvic floor physiotherapy. So now onto pelvic floor physiotherapy. If we've got a hypertonic pelvic floor, things can be very simple. If you've got a patient that either cannot afford pelvic floor physiotherapy or is unable to access pelvic floor physiotherapy, you can start on something as simple as asking them to do yoga positions like happy baby, adductor stretch, and child's pose. And different options for a hypotonic pelvic floor to try to strengthen that up would be clamshells, lunges, bird dog, and bridges. Kegels are effective, but the reason why they don't work is that they tend to not be performed correctly by patients. So we do get more effect by doing different exercises that incorporate large and small muscles, because those are easier for the patient to perform. It's easier for the patient to document, and it's easier for the patient to also get other growth of lean muscle mass and build bone density at the same time. Pelvic floor physiotherapists can have a lot of other options that they can use depending on what we are dealing with. In terms of vaginismus, dilators would need to be used, but they are not the things that are used initially. So please don't worry about patients needing to have vaginal penetration done as a first step. That's something that is done much later on in pelvic floor physiotherapy. You can see the curvy wand. The curvy wand is a pelvic floor wand, and that's used for strengthening. Dilated therapy can also be used rectally. Okay. There may be patients that want to do training in the privacy of their own home, and there are options like Lever, where we have home biofeedback. There's a little wand. This is inserted into the vagina. It's got its little protective carry case. And with a smartphone, you can be able to train the pelvic floor. There are different exercise regimes. It works on strength of contraction as well as lift and tilt, which the probe can be able to detect and tell the patient to squeeze in different directions and different intensities. And it's divided into different activities they need to do in the morning or in the night. And it can be linked with the pelvic floor physiotherapist's program to change it and to get feedback directly on their phone. We can also use transdermal electrical nerve stimulation and also using ultrasound. There can be fascial release, there can be cupping, there can be scar mobilization. There are lots of different options that can be used. With a hypertonic pelvis, we're tending to have 1 to 2 sessions per week. And this treatment will last about 4 to 12 weeks initially. And a hypotonic patient will need more sessions, 2 to 4 sessions a week, and that will be about 4 to 8 weeks in duration. It's just a list of some of the other options that the pelvic floor physiotherapists can offer. Okay. Other considerations are things like cancer patients and cancer treatments. When a patient is having a cancer-related surgery, the focus is getting out as much of that tumor as possible. So the focus isn't as much on maintaining their pelvic floor, but the surgery will depend on the tumor, where it is localized, the extent of debulking. If a patient is going to need chemotherapy at all, or a patient might choose not to have chemoradiation. If we do have pelvic floor radiation, there may be chronic pelvic floor fibrosis causing to pain. There could be vaginal canal narrowing and sexual, whereas sex was not an issue previously, it may be an issue now. With shortening, the male penis might feel too large, might feel too deep, even with shallow positions. There may be urine incontinence or dysuria, and there are negative effects of the ongoing hormonal treatments that may need to be given for cancers like breast cancers or other estrogen receptor cancers. If lymph node dissection was done, there may be chronic swelling in the genitals, the legs, or the abdomen, which may make it quite uncomfortable to have sex. And cancer by itself is an emotional stressor, which will exacerbate pelvic floor hypertonicity. HRT is safe after cancer in a large amount of patients. There are 9 million women diagnosed with cancer every year. It's not reasonable to make a blanket statement and say that none of them are allowed to have HRT safely. If we just look at gynecological cancers, in patients that are triple negative, it is suitable to use HRT in those patients. In patients with HPV-related cervical cancers, even adenocarcinomas, it is definitely suitable to use HRT. HIV-related cancers are in the vulva or the vagina, we're allowed to use HRT. If it's ovarian, it does depend on the subtype and how well differentiated it is, but we are commonly going to be able to have all of those results or to be able to ask for those results if the patient did not have the original surgery with you, and be able to assess if the patient is suitable. If there are patients that have other types of cancer, we need to also not give a blanket statement to them. Or if you have a patient coming to you for an annual gynae visit that you know has had a previous kidney cancer, thyroid cancer, that you can educate them that they are suitable to have HRT, even though possibly their thyroid surgeon, their colorectal surgeon may not have been aware that it is suitable for them to have these. So now getting onto a little bit of aesthetic gynecology. In patients that are having a pelvic floor surgery for a reason, that does not fall in the realm of aesthetic gynecology. If you are performing the pelvic floor surgery for a cosmetic reason, that is where it falls within the realm of aesthetic gynecology. And there is some crossover where we have patients that are presenting with a anterior prolapse, a posterior prolapse, and some hypertrophy of the labia majora. But not every single one of those surgeries falls under just aesthetic gynecology, because we are actually addressing an anatomical defect. So that's just something to be aware of. Aesthetic gynecology is not at all covered by medical aid. There are a lot of different options that we have. So they could be looking at repairing a perineum that's had previous tears, and that could be related to creating vaginal queefing. There may be laxity within the vaginal canal. That's something where we may look towards doing internal vaginal laser with the CO2 laser, or we may do a vaginoplasty and tighten the internal pelvic floor muscles. Labiaplasties are often related to weight loss or weight gain. There may be a single hypertrophic labia, but generally when patients come to me, the labia that they have an issue with is the one that has been normally developed, and the labia that they prefer and would like the other one to look like is actually one that is hypotrophic and has not grown correctly. Okay. Other options are things like a monsplasty. That sometimes in ladies that have had their tummy tucks, they tend to have more of a chunky mons because the fat has not been removed from that area. Fat transfers can be done in that situation. Clitoral hood reductions can be done in ladies that feel that their clitoral hood is too large, or if after scarring, maybe from lichen sclerosis, it became a little bit more fused around that clitoral hood and it's causing friction and pain. Hymenoplasties can be done either to recreate a hymen in maybe patients that are having a second marriage, or for somebody who has a tight hymenal ring where we want to excise the hymenal remnants better so that a patient can be able to use tampons, menstrual cups, and have sex without pain. Options are FemiLift CO2 laser. We've got radio frequency devices. PRP injections can be inserted into the vulva, can be inserted into the G-spot. They can also be inserted into the penis. There is laser genital bleaching, laser anal bleaching, vulval peels that are accredited for use in the genital region, vajacials, although that isn't doing something much more than what you would have done on your face. With steaming, exfoliation, there may be extraction done. Hyaluronic fillers can be used mostly in the labia where there was fat loss and we're trying to get more of a fuller look, and fat transfer, as I've said before. There are no studies that have looked at the effect of aesthetic gynecology on pelvic floor induced sexual dysfunction, but there are limited studies that have shown that different aesthetic gynae procedures will improve body image, will improve self-confidence, and will improve sexual function. Thank you, everybody. And I'm just in time with 1 minute to go.
Thanks so much, Marisa. That was excellent. And you were so comprehensive in the way you covered so many things. We had a lot to take in there, but absolutely wonderful. Yeah, so thank you so much. There are 2 questions here in the chat group. First one is from Puti Komotso. Would you recommend use of local estrogen-containing gels in patients that had required or had repair of acquired genitrizia repair? It's a tricky question, but yeah, I mean, what do you think? Genitrizia, is that? I don't quite know what that is, to be honest. Do you understand the question?
So, if there was atresia and there was poor growth in a certain area, if there wasn't anatomical formation,
yeah, I assume that, yeah.
You can absolutely use local estrogen treatments because they are not absorbed in significant amounts in the body. So this is something that's going to work topically. Absolutely. You can use it in the area that is atresic as well. I can't see a reason why it would be contraindicated.
No, absolutely. I agree with you. I think we need to use it more. I see often patients having been started on local estrogen creams when they have quite a few issues. I mean, so I think it's definitely something that should be used more. And you raised that point as well. Mondi Zungo has asked another question. When can aesthetic gynae be offered to patients? There is a growing group of teenagers looking for labia reducing surgery.
Okay. So there are a lot of aesthetic gynaes around, and some of them do treat patients younger than 18 years old. I only treat patients that are 18 years old and above so that they can make the decision for themselves and sign all consent forms for themselves. We also want to allow the teenage body to grow. And if you are performing these surgeries before there is full development, you may be removing a little too much tissue too early. So I would say, do not perform surgery in a teenager if it is purely for a cosmetic reason. Also address body dysmorphia, also address whether this is peer pressure, also address whether this is a view of what women should look like based on porn or social media. Because once we do that surgery, we can't put the tissue back again. The patient needs to know that this is lifelong, and with different life changes, their vaginal area will change even more. And having multiple aesthetic surgeries done means that we would be working on scarred tissue. So it isn't advisable to do it at an early age unless it is really needed, but try to keep it 18 years and above.
That's excellent. That's an excellent answer, and I agree with you 100%. It's a sensible approach to an important topic. Thanks so much. There aren't any other questions, and we have come to the end of our session. Thanks so much for your time and the great talk. I think we all gained a lot from that. Look forward to seeing you all next week when we have Toby de Villiers talking about endometriosis. And we wish Pete well tonight in his absence. Thank you very much, and thanks again very much.
Thank you, everybody. Bye-bye.
Thank you so much. Bye-bye.